Okay, good morning, everybody. So I have the honor and distinction of trying to present a scintillating, intellectual, and stimulating lecture on the hypothalamus and pituitary structure and function. I probably failed miserably, but nonetheless, let's go. So this is the guidelines from the ABOG Maternal Fetal Medicine Learning Curriculum. So they want us to go through metabolic clearance rate, transport and cellular binding, clinical effects and signs and changes during pregnancy, placental transfer, fetal effects, function, cellular mechanism, hypo and hyperfunction, fetal function, for the following hormones from today. So we will see what we can do to try to meet these standards. So, of course, we will start with a nice picture from Netters and trying to get a more macroscopic view of where the pituitary and hypothalamus happen to be. So here, you follow the line back out, you see the hypothalamic sulcus, and right underneath it is your handy-dandy pituitary. And so let's blow this picture up a little bit. I'm sure you all remember this picture from medical school. Some of us, it's more recent than others. And here you can go see, again, there's your hypothalamus, the pituitary stalk, and then your gland, the pituitary gland. And you can see all these different funky colors up in the hypothalamus all represent different nuclei, which are just different collections of neurons in the central nervous system, similar to ganglions in the peripheral nervous system. So here you have all these different nuclei up in the hypothalamus. And if you look below, and this is a point we'll be coming back to, you see these connections between the hypothalamus and the posterior pituitary. So, what is the hypothalamus? So, the hypothalamus is the region of the brain that's involved in coordinating the physiologic responses of different organs that maintain homeostasis, for example, to thirst, hunger, anger, fatigue. And it's part of the diencephalon, which is the forebrain, that's located below the thalamus, hence the name hypothalamus, and between the lamina terminalis and mammillary bodies forming the walls and the floor of the third ventricle. I highly doubt they would ask us this, but you never know. And the two halves of the hypothalamus are rejoined to form a bridge-like region known as the median eminence at the floor of the third ventricle. And the reason why this is important is because the axon terminals of the hypothalamic neurons release neuropeptides involved in the control of the anterior pituitary function, and they're also transversed by axons of the hypothalamic neurons ending in the posterior pituitary. So somebody can say English, please, and we'll get to that in a second. Before we get there, anybody know what this is? This is a sella turcica. This is what a Turkish saddle happens to look like. I'm sure we all wanted to know that. The pituitary sits in the sella turcica of the sphenoid bone, and we'll see why in a second, but you should all remember this picture that I took off the internet. It's flanked anteriorly by the trabeculum sellae and posteriorly by the dorsum sellae of the sphenoid bone, and the gland is surrounded by dura, and the roof is formed by a reflection of the dura, which is the diaphragmatic sellae. And the lateral walls of the gland are in direct opposition to the cavernous sinuses, and they're separated from them by the dural membranes. And the optic chiasm lies about 5 to 10 millimeters above the diaphragmatic sellae and anterior to the stalk. So here, I'm sure, is a flashback to those of you who all love histology. And you can see that there's different staining over here. There's the anterior pituitary, which is also known as the adenohypophysis, and the posterior pituitary, which is also known as the neurohypophysis. So the anterior pituitary, you can see, is bigger, if you include all of this part, up all there. It's about 66% of the volume, and it's composed of three parts, called the pars distalis, the pars tuberalis, and the pars intermedia. So I'm sure we all want to know what that is. There's the pars distalis, there's the pars tuberalis, because it looks like a tube. And somewhere in here is a little bit of schmutz, favorite word, which is the pars intermedia. And the pituitary, the posterior pituitary, is also called the neurohypophysis, and it's called the pars nervosa. Then there's this middle lobe, which some people think is the pars intermedia, a big question. And then there's always the pituitary stalk. So, I know we all love Jeopardy over here. Some pituitary trivia, I hope. So the anterior pituitary starts forming as early as 5 weeks gestation, and the hypothalamic pituitary unit is well developed by 20 weeks. And during pregnancy, the pituitary can actually double in size, which is mainly due to lactotrophs, which is those cells that produce prolactin. It is unlikely that this contributes to a lot of weight gain, but it's just important to know. So here, let's go back to some hanky-dandy pictures that we have. And you can see that this is a picture of the sphenoid bone over here. And you see how the pituitary gland sits so nicely in the sella turcica of the sphenoid bone. Anteriorly, there's this bone this way, posteriorly there's bone this way, and it's covered by dura, which is the diaphragmatic sellae. So, of course, we all want to know about the blood supply to the pituitary, because I'm sure you were all losing sleep from that last night. So, the blood supply comes off branches of the internal carotid artery, which we said before are lateral to the pituitary in the cavernous sinus. And off the branches of the internal carotid artery are the superior, middle, and inferior hypophyseal arteries. And these arteries form a very funky network, somewhat similar actually to the nephrons, a very funky portal network, which I think better deserves to be shown than to talk about. And of course, there's the venous drainage, which is always variable. The posterior lobe veins drain into the cavernous sinus, which drains into the petrosal sinuses, which drain into the jugular veins, which ultimately drain to brachiocephalic, and which ultimately drains into the superior the SVC, and then into the heart. So the axons of the neurohypophysis, which really start in the hypothalamus, terminate on capillaries that drain via the posterior lobe veins. And the hypothalamic hormones are secreted into the portal system, thus having quick and direct access to the anterior pituitary. So here is another picture from Netters. You can see over here, here's a superior hypophyseal artery. And you can see it forms this very, very funky network of a portal system, and these connections between the capillaries of the arteries and the veins. So why am I boring everybody with this? To show you that the hypothalamus connects to the pituitary through 2 different pathways. So as I said before, there is the posterior pituitary and the anterior pituitary. And the way that the hypothalamus connects and communicates with the anterior pituitary are through this whole portal network that's formed from the arterial system we discussed before. So that provides these signaling messages that get secreted into some of this portal network, which therefore communicates with the anterior pituitary. As opposed to the posterior pituitary, you got here the direct connection. You got here fiberoactive networks that go straight from the nuclei in the hypothalamus that go straight down, all the way down into the posterior pituitary, which then drain into the venous channel. So this is an important difference, that the posterior pituitary secretes their hormones directly into the venous system of the posterior pituitary, as opposed to the anterior pituitary, where it secretes their hormones into the portal system, which then communicates with the anterior pituitary. That being said, this happens quite quickly. You want your brain to send a message, the hypothalamus to send a message to the pituitary, and it has to be sent throughout the body in order to go back and reach the pituitary. That would be not good for survival mechanisms. So why are there 2 parts of the pituitary gland? I'm going to bring you back to medical school, probably to your first or second week of medical school, to the E-course, which is embryology. So whenever things don't make sense, think back to embryology. And here you can see, here's the roof of the mouth, and here's the floor of the diencephalon. And the roof of the mouth outpouches, something called Rathke's pouch, and abuts the floor of the diencephalon, which is outpouching inferiorly, and sort of meet each other and twist. This is the reason why the hypothalamus sends direct messages, and these axons terminate in the posterior pituitary. It's really just a direct connection from the hypothalamus. as opposed to the anterior pituitary, which has a totally different embryologic structure, but happens to meet the diencephalon right inferior to the hypothalamus. So that's the reason why we have these different mechanisms of signaling to the pituitary gland, and why there's a anterior and a posterior pituitary. Everybody got that? Yeah, well, so I saw from my research that didn't get accepted for this. Anyway, so let's now discuss the real meat of this lecture, which is the hormones of the hypothalamus. Come on, guys, this is fascinating. So the 5 hormones we're going to be discussing for the hypothalamus are GnRH, TRH, GHRH, dopamine, and corticotropin releasing hormone. So this is what they want us to discuss, so I'm doing my civic duty in discussing it. So the GnRH hormones are secreted from the preoptic area of the anterior hypothalamus, and their nerve terminals are found in the lateral portions of the external layer of the median eminence adjacent to the pituitary stalk. So all this means, and you're going to see this over and over and over again, is that you have these axons that are coming down from the nuclei. They stop in this median eminence, which is somewhere over here, and then they just get secreted into the portal system, which we discussed handy-dandy over here, and then they communicate with the pituitary. And you're going to see this over and over and over again in this lecture. It's a decapeptide, which means that it's a branch of 10 amino acids, and ultimately it's a messenger RNA that's 92 amino acids long, and then it ultimately gets spliced. So I'm sure you all wanted to know this. Here's your signal peptide. This little itty-bitty portion itself forms GnRH, and then you have this whole long funky GnRH associated peptide. GnRH, the half-life is 2 to 4 minutes. It increases during the first half of pregnancy. It reaches the anterior pituitary by about 20 weeks gestation. This is also a big thing in case we ever see it on the boards. Most likely, if you get a hormone, when does it reach the anterior pituitary? It's about 20 weeks. The levels of GnRH remain low during puberty, and the levels become pulsatile at puberty around the secretion every 90 to 120 minutes. And there's different frequencies of the GnRH. As there's low frequency, that usually stimulates FSH, and if it's high frequency, that usually will stimulate LH. And here you can see a picture from these are from monkeys, that you have, if you have pulsatile GnRH, you have an increase in the LH and an increase in the FSH as well. If you have continuous secretion of the GnRH, the FSH and the LH are suppressed. And then once you allow the GnRH to become pulsatile, you see the rise in the LH and the FSH again once more. Thyrotropin releasing hormone. So these neurons are located in the medial portions of the paraventricular nuclei. And here again, the axons terminate in the medial portion of the external layer of the median eminence. You can quote that to me. It's a tripeptide. There's 42 amino acids, 42 amino acids, and each gene produces 6 copies of TRH. And the half-life is about 6 minutes. And TRH is synthesized by about 6 weeks gestation. And this is just a picture of what TRH looks like. You can see here tripeptide 1, 2, 3. Growth hormone releasing hormone. Again, same spiel. It's located in the arcuate nuclei, and the axons terminate in the external layer of the median eminence. Growth hormone releasing hormone is also produced in the placenta. It's 44 amino acids in length. The half-life is about 3 to 7 minutes, which most of these are just minutes in terms of their half-life. That's a thing we should remember. And it's secreted too in a pulsatile fashion, and it's found in the fetus between 18 and 29 weeks. So dopamine from the hypothalamus, as opposed to other portions of the brain, that's why it's specific over here, is a prolactin inhibitory hormone. So we all know that it counteracts prolactin, and this is important for something we'll speak about later on. It's an amine, which means it's just one There's one NH2 group on it. It's not a peptide. It has a half-life of about 2 to 4 minutes. It's found as early as 3 months gestation. Sham spiel, they begin in the hypothalamus, the axons terminated in the external layer of the median eminence, and a disruption of the pituitary stalk causes an increase in prolactin secretion. Because the dopamine is being inhibited, so there will be an increase of prolactin. There's 5 forms of receptors, of dopamine receptors divided into 2 subtypes. The D2 receptors are mainly in the anterior pituitary, and with respect to prolactinomas, the treatment has improved with the advent of cabergoline because it has a D2 specific ligand, whereas bromocriptine is not as specific. And then there's corticotropin releasing hormone. Same spiel, the neurons are found in the anterior portions of the paraventricular nuclei. And these are actually found in all parts of the external layer of the median eminence. It's secreted by the placenta as well. Levels increase with gestation. And the half-life follows a biphasic pattern. In the plasma, the first phase is 6 to 10 minutes, and the second phase is 40 to 50 minutes after the secretion. And it's detected in the fetus at around 19 weeks gestation. This slide I put up here because they want to know how everything specifically works. So all the hypothalamic peptides are secreted via the median eminence. They stimulate the G protein coupled receptors in the anterior pituitary, and the anterior pituitary, the ligands of those are either G protein coupled receptors or cytokine receptors such as tyrosine kinase. I'm going to leave it at that to spare you the torture. So we're going to now move to the pituitary gland from the hypothalamus, moving inferiorly. Most of this stuff is self-explanatory. You have the anterior pituitary gland and the posterior pituitary gland. The anterior pituitary secretes TSH, ACTH, FSH, and LH, and growth hormone, and the pituitary secretes oxytocin and vasopressin. So this is a thing from Access Medicine, from endocrine physiology, and the trophs, when you look at these cells of the anterior pituitary, the trophs just mean cells. Lactotrophs produce milk, corticotrophs produce ACTH, thyrotrophs produce thyroid-stimulating hormone, gonadotrophs produce FSH and LH, and somatotrophs produce growth hormone. So here you can see the hypothalamic factor that influences the pituitary hormone that is produced. So prolactin, so 15% to 20% of the cells in the anterior pituitary produce prolactin, and as I mentioned before, there's a significant increase during pregnancy, which contributes to the increase in volume of the pituitary gland during pregnancy. It's inhibited by dopamine and stimulated by sucking and as well as estrogen. The role of prolactin is the stimulation of growth and development of the mammillary gland, synthesis of milk, and maintenance of milk secretion. Now, in patients who do not breastfeed, the prolactin levels rapidly decrease within 7 to 14 days postpartum. That's why it's important for those patients who want birth control who are not breastfeeding, especially those who are not breastfeeding, should get the birth control pretty soon after delivery. It's present in the amniotic fluid in high concentrations. Levels are about 10,000 nanograms per ml, are found between 20 to 26 weeks, and the levels decrease and reach a nadir about after 34 weeks. You can see this big, and they start to drop. And they're produced at the uterine decidua. And nobody knows why that prolactin is produced in the amniotic fluid, especially at such high concentrations. You can see here they did studies as to the levels of prolactin in the umbilical vein, in the newborns in the first days, and also as well as patients who are anencephalic. And you can see that in babies who are anencephalic, they still produce levels of prolactin. It's 199 amino acids long. It inhibits also GnRH, FSH, and LH. This has a pretty long half-life of about 50 minutes, as opposed to the hypothalamic ones, which had half-lives of 5 to 10 minutes. And the prolactin is present by 19 weeks of life. This is actually one of my most favorite slides, which basically summarizes all of REI. So here you have production. No, it does. Okay, that's it. This is where it's at, guys. The one slide, and everything else is just details. Yeah, two. So you have FSH that is secreted from the pituitary gland, which causes an increase in the follicles in the ovaries. The follicles in the ovaries produce ultimately estrogen, which causes the uterine lining to increase. Ultimately, after the FSH is being secreted, there is positive feedback from the estrogen being produced from the follicles, and you get a big LH surge. And within 36 hours, there is ovulation. Once ovulation occurs, there is progesterone that is secreted by the corpus luteum, thereby stabilizing the uterine lining for implantation should that happen to occur. If conception does not occur, there is involution of the corpus luteum and sloughing of the uterine lining, and the whole process repeats itself. How's that for Spiros? So FSH and LH share a common alpha subunit as well as with TSH, and there is a unique beta subunit. And FSH in the female targets the granulosa cells to promote follicular development, and that stimulates aromatase expression and inhibits secretion. And LH in the female stimulates steroid hormone synthesis in the theca and Turner cells, the lutein cells, and the Hylar cells, and that promotes luteinization and it maintains the corpus luteum. And both FSH and LH are suppressed during pregnancy. So TSH, again, is the same alpha unit as FSH, LH, and HCG. And it has a half-life of about 30 to 50 minutes, just as prolactin does. And it's responsible for cell growth of the thyroid. It stimulates iodine metabolism, and it induces changes in the thyroid cell morphology, specifically lysosome formation. And the alpha subunit from beta HCG can stimulate production of TSH, for example, in molar pregnancy. So whenever you're concerned about a molar pregnancy, we check the thyroid levels. Anybody ever wonder why? This is why. Because of the alpha subunit from the HCG will stimulate thyroid hormone production. So TSH levels can decrease in pregnancy, especially during the first trimester, and free T4 levels can be mildly elevated. So this graph over here just shows how the TSH, the black, this is 50th, 95th percentiles there. There's a decrease and ultimately a big increase. And the free T4 levels, again, follow somewhat the TSH production, although not exactly. ACTH is a 39 amino acid peptide. It's produced from pro-opiomelanocortin, which is actually a pretty funky peptide, which we'll discuss a little bit more. It stimulates the secretion of glucocorticoids, mineralocorticoids, and androgen, and it combined to the melanocyte-stimulating hormone receptor and cause hyperpigmentation because of the alpha MSH component. So we'll get back to that in a second. But it's actually pretty funky. ACTH is very funky during pregnancy. There's a 4 times concentration compared to the non-pregnant state between 70 and 10 weeks gestation. And then there's a 5 times concentration between 33 and 37 weeks gestation. And then there's a big drop right before birth. And then it increases again. During delivery, it increases 15-fold. So it's a little schizophrenic. Up, 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 down, and then back up again. And it returns to the pre-pregnancy level within 24 hours of delivery. And interestingly, the placenta secretes ACTH as well. So this, to me, is the most interesting hormone. Growth hormone is 191 amino acids. This growth hormone, it has a very prolific role. It's responsible for the longitudinal growth of bones, and that's why it's called growth hormone, because of the bones. It increases bone mineral density, and increases muscle mass, and increases glomerular filtration rate. It causes stimulation of the pre-adipocyte differentiation into adipocytes. It helps develop the immune system, and I did it twice there, sorry, but it's not that important compared to everything else. And it has potent anti-insulin actions in both the liver and the peripheral sites. that decrease glucose utilization and increase lipolysis. And the serum concentrations in pregnancy do not change, although the source of the GH changes. So there's a decrease in the anterior pituitary, and there's an increase in someplace else, which we'll discuss. But since I have this over here, oh, my monthly report is ready. I know this doesn't want me to. There we go. So you have the growth hormone releasing hormone, which stimulates growth hormone in the anterior pituitary, which targets the liver, the bone, the muscle, the adipocytes. And the way that growth hormone works is by the releasing of insulin growth factor type 1, which also stimulates secondary target tissues. Somatostatin, which is what SST stands for, inhibits growth hormone, and that's also produced, I believe, in the hypothalamus. So GHRH stimulates growth hormone, whereas somatostatin is inhibitory to growth hormone. So I mentioned before that the growth hormone levels remain stable during pregnancy, even though the anterior pituitary decreases the production of it, and this is because the placenta also produces growth hormone, and it only differs from the maternal pituitary growth hormone by 13 amino acids, and it's synthesized and secreted by the syncytiotrophoblasts, and by term, 85% of all growth hormone comes from the placenta. Interestingly, even though the growth hormone remains stable in pregnancy, the insulin and growth factor levels are increased during pregnancy. And placental growth hormone does not cross the placenta. So this is a good summary slide which tells you about the different growth hormone and even how it stains in the pituitary for those of you who are interested. This tells you the main hormone products, the structure of the hormones, in case they ask it. I hope they don't, but in case it's there. And also the functions of the major adenohypophyseal hormones and their sources. So POMC, which I'm just going to say for short. So corticotropin-releasing hormone stimulates the production, release, and processing of POMC, which is a pre-pro hormone synthesized in the anterior pituitary and is post-translationally cleaved to ACTH, beta-endorphin, and gamma-melanocyte-stimulating hormone. And the post-translational modification occurs in the pars intermedia, so they wanted me to discuss the middle pituitary, and perhaps this is where it's at. So here's actually a cartoon which states what I was saying actually a little bit more clearly. So here's the pre-pro hormone, which is post-translationally cleaved. And you can see over here in the N-terminalis you get the gamma melanocyte stimulating hormone. In the middle you have ACTH production, which ACTH is also cleaved in producing an alpha MSH, and this little clip which I don't know what it does. And then there's Then there's the beta endorphin that's being formed as well. So this pre-pro hormone produces ACTH, melanocyte stimulating hormone, as well as beta endorphin, which you can see over here, the three different pathways. And ACTH itself could also be cleaved, potentially producing more melanocyte stimulating hormone as well. So there's two sources from the same pre-pro hormone that can produce ultimately melanocyte stimulating hormone. So now that we discussed the anterior pituitary, I know we're all very excited to discuss the posterior pituitary. And there's only two hormones in the posterior pituitary, thankfully. And remember that the posterior pituitary is really a direct extension of the hypothalamus. So oxytocin, which is I call vitamin P, pitocin, is formed in the paraventricular and supraoptic nuclei in the hypothalamus. It's a cyclic nonapeptide, so there's 9 amino acids, and it only differs from vasopressin by 2 amino acids. So we all know that one of the side effects from oxytocin, if we give too much of it, is water intoxication, SIADH. And the reason why is because oxytocin and vasopressin are structurally very similar. So we all know oxytocin stimulates the frequency and the force of uterine contractions. It And stimulation of the breast also induces oxytocin secretion, which causes contraction of the myoepithelium, which forces milk from the alveolar channels into large collecting sinuses and therefore available for the baby. And the half-life is about 12 to 15 minutes. Oxytocin is also produced by the placenta, and is actually 5 times that of the posterior pituitary. And circulating levels of oxytocin are low throughout pregnancy, and they only increase right before the second stage of labor. And oxytocin receptors are present in the myometrium and increase dramatically in number only shortly before the onset of labor. And it can also stimulate the production of prostaglandins by the human decidua. So this just brings up the question, the reason why this is interesting is sometimes we will induce people at 32 or 33 weeks with oxytocin, and the question is, at least from a basic science standpoint, does it work? Because you're giving them all this oxytocin, and you have no receptors, or minimal receptors, for the oxytocin to work, especially if we do it early. So just something to think about. Coffee talk. Vasopressin is also a cyclic nanopeptide, and this increases water reabsorption by enhancing permeability to water and the distal convoluted tubules and the collecting ducts in the kidney, and it also increases vascular resistance. Now, in pregnancy, the plasma osmolality decreases a little bit, but the plasma levels are normal in pregnancy. So basically what this means is that the brain sort of resets the threshold of when vasopressin is going to be secreted. So what is this talking about? I don't know if you guys can see this over here, but you can see here the osmotic threshold here going 270 to 280. The osmotic threshold is 282, thirst is 292, and then you get urine osmolality, which ranges between 200 and 1,000 and produces urine volumes. And this is before pregnancy. As opposed to during pregnancy, everything is really pushed down a little bit. The osmotic threshold is 272 as opposed to 282, not during pregnancy. And thirst is at 282 as opposed to 292. But the urine osmolality is really the same. It's just a resetting of the threshold. I'm sorry, it's reduced a little bit, but in essence, it's very similar to that of the pre-pregnant state. So this I put over here because to remind me to look at this. I'm not going to go over all of this. They asked in the guidelines to discuss how to interrogate the efficacy of the hypothalamus. So there is all these things that I sort of long forgot about from endocrinology, about the ACTH stimulation test, the GHRH arginine infusion test, growth hormone suppression test, TRH test, GnRH test, and what have you. So I will put this up. It's boring, and I'm not going to torture everybody with reading all this, but it will be available for your reading pleasure whenever you have insomnia. Okay. I don't even know how to do this. Sorry. So we're just going to run through all this one more time because I know you all love it. Okay. And this is just again just a cartoon of how to examine, how to interrogate the hypothalamus and its function on the pituitary gland. So this is where we get more meat. So the summary of the maternal pituitary function changes during normal pregnancy. So prolactin will increase progressively throughout gestation, and postpartum it's stimulated by suckling, and it falls rapidly in the absence of breastfeeding. Gonadotropins are suppressed in a few weeks and remain low throughout gestation, and in the absence of breastfeeding, return to normal within 1 to 2 months. Thyrotropin, there's really no changes except for transient dip at 9 to 13 weeks gestation. Growth hormone is suppressed during the second half of gestation, and it returns to normal within a few weeks postpartum. Corticotropin, there's a probable modest increase in plasma ACTH, and we discussed the schizophrenia of the ACTH, and it returns to normal within 1 week. Vasopressin, there's no change in plasma levels, though the production rates increased in the third trimester. And oxytocin, there's no change except for the increase in plasma levels during labor, and postpartum is stimulated by nipple stimulation and maternal cyclic factors. So do hormones cross the placenta? Yes and no. So IgG, thyroid hormones, catecholamines, and steroid hormones do cross the placenta. A bunch of them undergo modification within the placenta. But peptide hormones, which is most of the hormones from the anterior pituitary as well as the hypothalamus, do not cross the placenta because they are too big. Okay, that's a general rule. So, fetal development of the hypothalamic pituitary axis. So, about 5 weeks, the diencephalon and Rathke's pouch form. 7 weeks, the hypothalamus and the posterior pituitary are fully formed, or at least the outline is fully formed. 8 weeks, the capillary system, and 12 to 17 weeks, the portal system are formed, and between 12 to 18 weeks, the hypothalamic nuclei are formed. And in terms of the hormones, between 10 to 14 weeks, GRH, GnRH, and somatostatin are produced, and they can be found in the fetal plasma. 10 to 17 weeks, the anterior pituitary hormones can be detected. In 15 to 18 weeks, CRH can be corticotropin-releasing hormone can be detected as well. So we see, I'm going to show you some graphs of this as well, that basically by 20 weeks, you can see detection of these hormones. So, I have 4 graphs like this. It's just very funky to see how the growth hormone increases and then decreases. The prolactin levels are very interesting in that they're really, really low up until about 30 weeks, and then there's a big secretion of the prolactin levels in the fetus. ACTH, which we discussed before. This doesn't show the funkiness that I showed before, but the cortisol levels you can see really increases in the fetus. And as we all know, there's a question whether cortisol levels stimulate labor, or that's still a question, I believe. And here you can see the TSH and the thyroid hormones actively increasing during pregnancy. T3 goes down and then increases, but I think the TSH in this 54 is really what you want to look at. And in the male fetus, at least, they didn't have female, sorry. You can see increase in testosterone, and then goes down, and then after birth, testosterone goes up. And you can see the HCG goes down, which I presume would be the same for the female fetus as well. So, we actually had a case like this a couple of weeks ago, about a patient who had signs and symptoms concerning for Sheehan syndrome. So Sheehan syndrome was first described in 1937, and postpartum hemorrhage causes anterior pituitary necrosis because the pituitary is so hyperplastic, especially by the end of pregnancy. And interestingly, the amount of hemorrhage does not directly correlate with the amount of necrosis. And there are acute and chronic forms. The chronic form may not be diagnosed until years after the event. So this is just a picture of what Sheehan syndrome is. Here you can see the pia mater, and there's the arachnoid and the dura, and here's the pituitary. And when a person has Sheehan syndrome, you can see that the pars cystalis is much, much smaller than it is over here, and you can see there's a herniation of the cerebrospinal fluid into the space where the anterior pituitary was. So all this has been obliterated. The acute form is hypotension, tachycardia, failure to lactate, hypoglycemia, and extreme fatigue and nausea and vomiting. And really, it's the failure to lactate that is going to really trigger your concern, because hypertension, tachycardia, fatigue, we see for many, many other reasons as well, not just Sheehan syndrome. The chronic form presents itself, again, amenorrhea. The main things are persistent amenorrhea and failure to lactate. There's fatigue, dry skin, loss of libido, nausea and vomiting, and cold intolerance. So, the management and treatment of patients with Sheehan syndrome. So patients with Sheehan syndrome have gotten pregnant, and the suspicion is raised based on a history of postpartum hemorrhage as well as symptoms. And you want to check the TSH and free T4, and they will both be low in Sheehan syndrome. And you also want to check the ACTH simulation test, and cortisol will not rise appropriately. The live birth weight for patients who have Sheehan syndrome is much higher in patients who are given hormone replacement compared to those patients with Sheehan syndrome who were not given hormone replacement therapy. By that, I'm not talking about estrogen, I'm talking about thyroid hormone and stress dose steroids. You want to give them alpha-roxin in doses of 0.1 to 0.2 milligrams daily, and you want to try to get them in the mid-normal range. And you want to give them corticosteroids. There's different ways of doing it, either using cortisone or prednisone, and you want to maintain this dose. Mineral corticoid replacement is usually not necessary because production of aldosterone is not solely dependent on ACTH stimulation. And in labor, like we usually do, we want to give them IV glucocorticoids. And usually the easiest way to do this is to infuse hydrocortisone, and you want to make sure they have adequate hydration. Another syndrome where you can have some sort of insufficiency is Kallman syndrome. There's isolated gonadotropin deficiency, and the reason why this occurs is because of hypoplasia or aplasia of the olfactory lobes and the olfactory bulbs, which cause hyposmia or anosmia. And the GnRH-containing neurons are actually initially formed at the olfactory placode, where they originate, and they migrate to the medial basal hypothalamus. And so if there's going to be hypoplasia or aplasia of the olfactory lobes, the GnRH-containing neurons are not going to form. There can be associated abnormalities which affect the kidneys and bone. Patients may have undescended testes and gynecomastia. And I have to put this in, there are multiple genes that cause Kallman syndrome. They could either be inherited on an autosomal dominant, autosomal recessive, or X-linked fashion. So we get all three types over here, which makes counseling very difficult unless you know the actual gene that's affected. Treatment in females of Kallman syndrome, if fertility is not desired, you can give them unopposed estrogen to aid in breast development, and once that has been accomplished, you want to add a progesterone derivative to protect the endometrium. If fertility is desired, you want to administer pulsatile GnRH, or you can actually give them FSH or LH directly. Other causes of pituitary insufficiency include pituitary adenomas, tumors, infarction, sarcoidosis, hemochromatosis, histiocytosis, trauma, surgery where the pituitary is affected, infectious disease, idiopathic or isolated, such as Kallman syndrome. And the last 10 minutes I'm going to discuss something that Erin Dickert started on last July. So some of these are her slides, and I'm going to add to it a few slides of my own at the end. So peripartum cardiomyopathy, this is actually an increase that I think you mentioned this 2 weeks ago, Dr. Martin, in terms of how do we treat, or is there a way to treat peripartum cardiomyopathy? So we all know that peripartum cardiomyopathy is an acute onset of left ventricular systolic heart failure, usually in the last month of pregnancy or first 5 months postpartum. I sort of move this down, but basically there's really no other identifiable source of cardiomyopathy. The left ventricular ejection fraction is less than 45%. And the prevalence differs based upon where it is, whether it's in the US or Africa, or it's actually much more prevalent in Haiti, and it's treated as a form of dilated cardiomyopathy. And usually 25 to 50% of patients show recovery of cardiac function within 6 months. But the mortality is very high, it's about 15% worldwide, and only about 30% of patients make a full recovery. And the treatment is impaired because it's really a diagnosis of exclusion, or you have to at least think about it in terms of your differential, because the symptoms may overlap with other peripartum symptoms. The peripartum cardiomyopathy is hypothesized to be a pro-inflammatory condition. There's a correlation between BNP, prolactin, markers of oxidative stress, and inflammation. And all of this is mediated by, of course, we all thought about this, cathepsin D, which is a lysosomal enzyme. And that cleaves prolactin into an anti-angiogenic, pro-apoptotic, pro-inflammatory agent. And it promotes apoptosis. It disrupts capillary structures, and it impairs cardiomyocyte metabolism and contractility. And this was a initial paper that was published in Circulation, where they enrolled 20 patients with peripartum cardiomyopathy. They all received furosemide and enalapril, and they either received this therapy or they added on bromocriptine. The groups were similar in terms of their demographics, and one patient from the bromocriptine group died 7 days after presentation, and 4 patients in the normal group, in the control group, died within 6 months following the 6 months follow-up. The left ventricular ejection fraction was higher in the bromocriptine group, and the survivors in the bromocriptine group were NYHA class 1. And here you can see, it's difficult to see here, but the black bars are those patients who did not get bromocriptine therapy, and the white patients are those patients who got bromocriptine therapy. And you can see that in terms of the death, those as an outcome, which is the ultimate outcome, the death was much, much higher in those patients who did not get bromocriptine than as opposed to those patients who did. Now, granted, this was only a small amount of patients. The same group, 2 months ago, published phenotyping in an outcome on the contemporary management of the same German cohort of patients with peripartum cardiomyopathy. So this is now what they think their mechanism of action happens to be, and don't worry about this. And I also have it their the way that they interpret the figure, but we'll just go over it. So you have the pituitary gland, which produces prolactin, and prolactin can get cleaved by cathepsin D into a smaller form of prolactin. And this prolactin, this form, causes an increase in miR-146A. So what's this miR? Besides the city in Russia, miR is microRNA. And microRNAs are believed to be these small RNAs, about 20 base pairs in length, that are believed to turn on and off genes. And this is actually a very interesting topic that's under a lot of investigation in many different diseases. But in any event, this prolactin causes an increase of this miR-146A, which produces these microparticles, which can increase, which first of all changes the contractility and the function of the myocytes, and also increases BNP in the patient. So they think that the whole culprit that's being stimulated by this funky prolactin level is this miR-146A. And if you give bromocriptine, you stop or you inhibit the process. Okay. So they have these 115 patients with postpartum cardiomyopathy or peripartum cardiomyopathy. 96 had follow-up after 6 months. This is really a retrospective review, but it's from data, some blood they already had. And some patients received bromocriptine for 4 weeks after diagnosis in addition to standard therapy, and some didn't. This thing over here, that's a little bit difficult to read, you can see this is the BNP. So those patients who are controls who did not have peripartum cardiomyopathy had a smaller amount of BNP. They also had and the patients with peripartum cardiomyopathy had a higher amount of BNP. The same thing with ADMA, which is a stress marker. And the same thing with cathepsin D, although you can see that there's a wide range of the values. So in terms of the serum levels of miR-146A, it's much, much higher compared to the controls of those patients who had peripartum cardiomyopathy, but it's actually a little bit lower in those patients who had already been treated with bromocriptine.
Do you know when those serum samples were?
They were within 6 months. What the exact time is, I don't know. I think it's when I believe this was all within 6 months of the diagnosis. Some were diagnosed antepartum and some were diagnosed postpartum. So it's not exact in terms of your comparison.
This particular one-year product, is it maternal or fetal?
I believe it's maternal in origin. So in terms of the outcomes, so I'm sorry about that. Should be improved. So 85 out of 96 patients had improved outcomes, and that means that either the ejection fraction increased by 10%, or they improved in the NYHA status. And 14 out of 96 patients did not improve, and that means that either if they showed up at the follow-up visit, and they either had a ejection fraction of less than 35%, or they failed to improve by 10 units, or they remained in the same class, or they died. And flow recovery was defined as reaching a ejection fraction of more than 55% and they were only in class 1 to class 2 in terms of the NYHA classification. So when you look back at the characteristics of those patients that did not improve, those patients who did not improve started off with an ejection fraction of less than 25%. And the vast majority of them also did not receive bromocriptine as part of the therapy. And if you see over here, you can see those who improved, so 72% received bromocriptine, although 35% did not. And you really have to take all of this into consideration when you're going to make your conclusions based upon the study, because you have to take into consideration whether they can receive the beta blockers or the ACE inhibitors and what have you. So it's not that obvious that it's the bromocriptine that's improving their outcome, but it's definitely associated with an improved outcome. But the reality is that we need a randomized multi-center trial, which is still being performed in Germany. They're trying to randomize 60 patients to bromocriptine therapy or not bromocriptine therapy. And when I looked at clinicaltrials.gov a couple of days ago, it says that this was last updated in September 2012. So I have no idea what they're up to at this point. Questions? The German. I don't know. I presume that they're Caucasian, but I don't know specifically. I'm sorry? Yeah. They can start.
I think in the regional nature of the there has to be some, I guess it could be environmental,
Genetic.
it could be genetic, there has to be some
It's very high.
I don't know if that's in class or what.
Yeah, I don't know. Questions, comments, complaints, besides it was long? Okay. All right. Thank you.